Dr. William Baione. He's from Hackensack Meridian Hospital Network. He has an office in Wall Township. You're an orthopedic.
Surgeon.
And he's going to talk today about total joint replacement.
Good morning, everyone. Thanks for having me. Okay, we're going to get the lights. So today's lecture is a general overview about arthritis treatment. We're going to focus a little bit on non-operative treatment as well as some of the surgical indications for total joint replacement. This is an open, informal format, so if someone has a particular question that's pressing, just raise your hand. We can address it at the time. If not, at the end of the talk, we'll have plenty of time to answer any questions that you may have about joint replacement. So we're going to get started. This is just a little information about my group. I'm part of a group called the University Orthopaedic Associates. Our group has been in practice for over 40 years, initially established in New Brunswick out of Robert Wood Johnson. We have multiple offices in the area as they've expanded, and so I practice mainly out of the Wall office here on 34, and we operate mainly out of Jersey Shore from that office. Our group consists of 16 orthopedic surgeons with various subspecialties, from joint replacement to hand and upper extremity surgery, spine surgery. So it's sort of a one-stop shop. If you have an orthopedic problem, we have specialists that can address any of those problems. Specific to me, a little bit of background. I'm originally from Brooklyn, New York. I did my undergraduate training at the University of Miami. I have a background in biomedical engineering. I went to medical school at Cornell in New York City. Completed my orthopedic residency at Robert Wood Johnson, and then went down to Tampa to Florida Orthopedic Institute to round out my joint replacement training. My general practice guidelines, this is a picture of my son wearing scrubs. My general practice guideline is, I'm all about education. I think a big part of treating patients that have any kind of problem, but specifically orthopedic problems, is you have to have an understanding of why you're having the symptoms that you have. And if you clearly understand what the solutions are, and I can convey that to you, I think it helps with your recovery. I think one of the problems with surgery and specifically joint replacement is expectations, really understanding what you're signing up for if you become a candidate for a joint replacement. So osteoarthritis is very common. It affects a large proportion of the population. Here is one study in particular saying 17%. There's a large cost associated with this. I'm pretty sure everyone in this audience has felt the sting of the government either changing your benefits, working with Medicare and Medicaid. This is something that costs the insurers and the government a lot of money. So on the one hand, it's about controlling cost, but I think rather than cost, we want to improve the quality of the care that we provide. And so there are constant changes that are being put on the patients, but also on us as the providers. This is basically a summary slide that, even if you can't read the axis, it's basically saying that as we move forward in time, people are getting older and living longer, so we project that we're going to need to do a lot more joint replacements. So we need resources and people that are trained to tackle these types of problems. One of the things that pertains to joint replacements that have been happening is that there's a rapid growth in the number of joint replacements that are done in this population here, what we call the 40 to 60 age group. And the reason that is that years ago there was the adage that a joint replacement might only give you 10 years, and some of that was due to the materials that were available. We have current implants in terms of how they're developed that have a longer life, that you can approach, over 20 years, 25 years in some cases, with a joint replacement that can function well. And so the ability to do that allows us to do these replacements in younger patients if they meet criteria. In general, a lot of people confuse what arthritis actually is. I get that question all the time. Doc, everyone tells me I have arthritis, but what is arthritis? So arthritis is essentially inflammation that's associated with radiographic, meaning X-ray degenerative changes, where you have loss of the cartilage of your joint. There are different types of cartilage. Osteoarthritis is what I call wear and tear. That's just living a long life, being an athlete, working a job, just wearing the tire down, Inflammatory arthritis, a lot of people think they have rheumatoid arthritis, but unless you've been tested for it, you have specific antibodies, everyone seems to think they have a relative that has rheumatoid arthritis, but it's less common than we think. And so that's a distinct difference, that sometimes if you actually do have rheumatoid arthritis, in addition to surgery, there are also medical treatments that are necessary to address your symptoms. And then there's post-traumatic arthritis that happens sometimes when someone has an injury where they fracture one of the joints, they have a hip fracture, a knee fracture, that knee goes on to become arthritic, and even though they've healed the fracture, they have the symptoms of a worn out joint that may or may not require joint replacement. And these particular cases are more complicated because there's often hardware that's present, a plate or a screw, so some of the technical challenges of how we do the operation may change. This is just a picture of what arthritis looks like. These are images from an arthroscopy, basically a scope where the camera is looking into the knee. And here on the left side, you can see this kind of white material. This is a probe kind of pressing on it. It sort of looks like an eggshell. So when arthritis develops, that cartilage starts to wear away, and underneath the cartilage is bone. And so many people have heard of the term sort of bone on bone. And so you can almost imagine that what was this once smooth joint surface that was lined with synovial fluid is now kind of like sandpaper rubbing. And when you talk to patients, that's what they describe. They feel all this cricking and cracking and popping, and it's uncomfortable and causes pain. So this is just an x-ray specific to hip arthritis. So I see a lot of patients every day in the office that talk about their hip hurting. And so when you say my hip hurts to the patient, it means a lot of different things. They kind of point in this general area. Sometimes it's their buttock, sometimes it's the side of their leg, sometimes it's their thigh. But classically, if you're talking about arthritis, the typical symptoms for hip arthritis is actually thigh and groin pain. It's a very sharp pain in the groin. When you think about anatomically where the hip is, it's actually right here and not out here on the side. These are the muscles that are on the outside of the hip. So this is just an x-ray that shows where the cartilage is. And then if you look at the next one, you can see that that joint surface is worn away. And this is what we call bone on bone. And so people that have this x-ray tend to have difficulty walking, standing for long periods of time. You may notice that it's more difficult to put on your socks and shoes. It probably hurts to get up out of a chair. Your leg doesn't quite move the way that it did. You might walk with that foot outward. These are all physical exam findings that are consistent with this x-ray. So I tossed in a few slides about knee replacement. So by association, you can also see that the same process can happen within the knee, that when the surface between the bones wears out, that is what we call arthritis of the knee. And you can have arthritis in different parts of the knee. So other terms people may use are called global, or what we call tri-compartmental osteoarthritis, meaning involving all three compartments of the knee, the inside, the outside, and the kneecap. And so we'll talk a little bit about the specific replacements that are used here. So as a patient, when you have this problem, you kind of ask yourself, well, you know, I have these symptoms, like I need help, you know, I'm in pain. You often find that once your mobility is affected, it affects your quality of life. You probably don't get out as much as you did. You find it more difficult to go to church, to go shopping, to play with your grandkids. And it actually affects how you live your life. And so this is a question that I often encounter when I meet new patients, that they have all of these symptoms. They have x-rays that show they have arthritis, but they've either heard or have been told that they're quote unquote too old to have a surgery. And so what I'm going to try to do during the course of the talk is to explain that in general, we don't look at age as a limiting factor of when you can have an operation. It has more to do with your physiologic function, that if you're healthy enough to tolerate the procedure and you have several years ahead of you, there's no point living with a very low quality of life that affects the years that you have left. And so that's what I often tell people. I was like, unless you're so unhealthy that the operation would actually kill you, then I don't want to do that. I don't want to hurt anyone. But if I can make your life better with an operation and it's safe to do so, then I think that's a service to patients, as opposed to just putting up the stop sign and saying you're too old for a procedure. I don't think that's fair to the patients. These are just some general treatments. These are classes of what we call analgesics, anti-inflammatories, injections. I'm going to go pretty quickly through this, but these are just some of the conservative treatments for arthritis. The bottom line is we don't have a cure. Once the cartilage is worn away, we can't make the cartilage grow back. So a lot of the treatments that are available are aimed at the symptoms. We're trying to decrease the pain, keep the motion that you have, improve your mobility. But the definitive treatment, once the joint is worn out, is a replacement. So this is the treatment plan: education, weight loss, activity modification, medications, braces, and then surgery. So we don't start with an operation as the very first thing that we offer. We often want patients to exhaust conservative management. So exercise, this is something that even if we were to replace your joint, I often tell patients, we don't give you new muscles, you know? I put a new tire on the car, I aligned the axle, but I didn't do any engine work. And so if you were weak and you didn't have good balance before the operation, the surgery does not magically give you strength and balance. That's something that you gotta work at with physical therapy. And so there's a role for what we call prehab, essentially keeping the motion and the strength that you have before you have an operation. So anything you can do to stay fit, work on strengthening your muscles, I encourage patients to do that even before they have an operation. Activity modification, I call it the common sense rule. You know what hurts, so if there's a particular activity that you're doing that's causing pain, stay away from that. Find shortcuts in life. Take the elevator, use an escalator, walk with an assist device, a cane. These are some simple things that you can do that avoid an operation but limit the episodes of pain that you may have. People come with different kinds of treatments. There's acupuncture. Some people have gone for this. In general, for the treatment of arthritis, it might relieve some of your symptoms, but when you look at the evidence, the studies behind this, they're weak at best. And so if you get relief from something like this, it's really not going to do any damage to you, but it may be a waste of money in terms of actually treating the source of the arthritis. Bracing. A brace is only good if you're going to wear it. Some people find having that little extra support is helpful, but I often see patients that ask for braces, and then when I see them the next time, they come in and the brace is at home. And then I say, well, where's the brace? And they're like, well, it's in my drawer. And I said, well, it doesn't brace anything if it's sitting at home. So you got to wear the brace for it to work. But sometimes they cause more pain. A lot of people come in talking about supplements, you know, chondroitin, glucosamine, similar to other supplements. The studies behind these medications are weak at best. Some people think there's a little bit of a placebo effect. In terms of cartilage, these are components of normal cartilage that your body is going to digest when you eat this pill. So I'd rather get my protein from a steak than eating these expensive pills that don't taste good. Anti-inflammatories. This goes anything from Advil, Aleve, Motrin to certain prescription forms. They make them as pills as well as topicals. The problem with these medications is I think they do a good job at decreasing inflammation and reducing pain for patients. It's one of the mainstays of conservative treatment for arthritis. The problem is that it interacts with a lot of other medications. So if you're on blood thinners, if you take certain blood pressure medications, if you have bleeding ulcers in your stomach, you have kidney problems, there's often interactions that limit a patient's ability to safely take these medicines. And so it almost takes something that we know works pretty well to give people relief and takes it off the table. And so sometimes that becomes a situation where the next logical step is to go to pain medication, narcotics, and things like that. I think the long-term management of arthritis with narcotics is not a good long-term plan. There's a lot of side effects and problems that come from narcotics. So if you're at the point where you can't take medicine anymore, your joint is worn out, and there's nothing left, I think going to pain medication as opposed to fixing the problem is not a good solution. Tylenol, people often ask, they're told, well, I can't take these other medicines, but I can take Tylenol. Tylenol's processed through your liver, so it doesn't interact the way that some of these others do, but Tylenol is often a little weak when it comes to decreasing inflammation. It's more of an analgesic. You know, we give it to children for fevers and pain, so how strong could it be? Injections, so there's the quote-unquote steroid shots. People often get released from this. These are steroidal anti-inflammatories as opposed to non-steroidals that I just showed as those pills. The relief that people get from this sometimes can be very significant, 100% relief that often lasts for several months. And like many things in life, you often run into diminishing returns. It works really well initially, might work for a year, 6 months, but then you get to a point where it stops working. And it's not necessarily that the medicine doesn't work anymore, it just may be that your arthritis has progressed to a point that it's beyond these injections. If you are getting less than 3 months of relief from an injection, repeated use of steroid injections, a month apart, 2 months apart, can lead to long-term problems with infection, ruptures of tendons, things like that. So it's safe to do it a few times throughout the year, but if you find that you need it more often, and they're doing them very close together, that's sort of indicating that you might be past that treatment in terms of conservative treatment. There's other types of injections. Everyone knows about this. They call them the gel shots, the rooster comb shots. They're usually given as a sequence of injections. To be honest, we don't know how this medication works. And I know that sounds silly, but essentially it's a component that interacts with normal cartilage and synovial tissue by stimulating the tissue in your knee to create a healthier joint fluid. So it's sold to patients as being a type of lubricant. And for some patients that still have cartilage, I think there's a role for this. But if you come in with bone-on-bone arthritis, big bone spurs, no joint space at all, the amount of relief that you would get from these injections is unpredictable. And sometimes patients do this, and then within a few months are already back to square one. And so it makes you question whether or not that injection was worth it. I know people sometimes think of injections as being pretty safe, and in general they are, but they're not benign and they are a procedure. I'm not here to talk about places or things like that, but there are groups that advertise to seniors on flyers, on the radio, talking about doing special types of injections with X-ray and ultrasound, putting dye into the knee. And last year there was an outbreak caused in this area that led to 50 infected knees that all presented to local hospitals, all from a local clinic that was doing these types of injections. I personally took care of a lot of these people that had the infections and went on to needing joint replacements. And when you look at how their knees looked before these injections were happening, I think an educated discussion with the patient about their symptoms might have shown them that maybe they were past the point of injection. So all I say is just be careful who you let inject your knee, and more importantly, what they're injecting into your knee. Another thing that people talk about are stem cells. That's a hot topic. I think stem cells are promising. I think they have the ability to decrease some inflammation and things like that. But sometimes patients think, the way it's sold to them, that somehow it's a magic pill, that it's gonna grow cartilage in your knee. And no study has demonstrated that that's what they do. And the kicker for me, and why I don't do them, is because when the joint is worn out, if you have something that's not necessarily approved by the insurers and the FDA specifically for that indication, that you have to charge patients out of pocket anywhere from $500 to $3,000 for an injection, you're already on a limited income, and you have something that isn't going to promise that it's going to fix, to me, in my hands, I don't really see a role for it, for the treatment of arthritis. And I see a lot of patients that mustered together the money, they're so scared of surgery, they paid $2,000 for an injection, and then when the injection doesn't work, they're in my office talking about hip replacement or knee replacement, and that $2,000 went down the drain. It didn't really give them any benefit, and they wind up having surgery anyway. So again, just be careful, and everyone in this audience probably knows that if it sounds too good to be true, it probably is, right? So people come in with MRIs of their knees all the time. Meniscal tear, that's a big topic. If you have arthritis and you're 70 or 80 years old and you got an MRI on everyone in this room, 50% of you would have degenerative meniscal tears, whether you had symptoms or not. That's what the meniscus does. And so what the purpose of this slide is that if you have arthritis and meniscal tears and you're a senior citizen or an older patient, sometimes arthroscopy, doing a knee scope to go in and scope the knee to quote unquote clean up the meniscus, may actually result in increased pain after the operation. It's not always going to happen, but for me is if you have an arthritic x-ray where there's no joint space, to go in and do an arthroscopy is very unpredictable and often can make patients worse. And so this is basically saying that less than half of patients had a reduction in pain. So if you wind up needing a knee replacement within a year of doing the arthroscopy, it makes you wonder if it was worth it to do that procedure. How much bang did you get for your buck there? Hip arthroscopy falls in the same category. It's limited. It really only has a role in younger patients, athletes. people that still have preservation of their cartilage. Once you have degenerative changes on the x-ray, the utility of these arthroscopic interventions is limited. So when we talk about joint replacement, it's the gold standard. It has a good track record. It's tried and true. If it's done correctly, you can have many years of longevity, and it often does a good job at completely relieving your pain. But again, I led this talk with expectations, and so a lot of people have their joints replaced but aren't always happy with the result. And so it makes you question what their symptoms were sometimes before the operation. And so if you operate for the right reasons, you understand what you're doing, I think patients do a lot better. So this is something I see all the time. Someone comes in and I haven't even said a word to them and they said, someone told me that I need a joint replacement. And so should you have your joint replaced? If the answer is you failed conservative treatment, the medicines, the injections, therapy, if you have pain that affects you on a daily basis and you understand what the procedure is, then that's probably why you should have a joint replacement. In contrast, if you come in and you actually doing okay, but your daughter says that you need a hip replacement, you have a friend who had a hip replacement, and you think that you might be too old if you wait till next year, so you're just gonna do it prophylactically, these are bad reasons to do joint replacements. You should do them when you have symptoms and you have failed conservative treatment. And that's something that you'll determine talking it out with the surgeon. So if you sign up for a replacement, what would you expect it to do? Once you've been indicated, you fail conservative treatment, you have arthritis on an x-ray, you have clinical symptoms that affect your quality of life, then the process tends to start. You have a preoperative workup, you see your primary doctor, you have some x-rays, basic lab work, and you're essentially cleared. A lot of the hospitals here at Meridian Hackensack have joint replacement classes that are available to patients to give them education about what to expect, the hospitalization, and so I encourage patients that sign up for surgery to attend these classes. It's beneficial to get that information. What we try to do is eliminate risk, and so if you're a smoker, stop smoking. If you're a diabetic, we try to get your blood sugars under control. The number that we look at for diabetics is your hemoglobin A1C. Ideally, we'd like it below 7. If you come in with a hemoglobin A1C of 10, that means your diabetes is very poorly controlled, and you put yourself at significant risk for having complications at the time of surgery in terms of wound healing, complications related to drainage, problems with the implants loosening, things like that. And so it's not that we won't operate on you, it's just we want you to be a little healthier. And so often that takes a little coordination with your primary doctor as well as your endocrinologist. A lot of people think that historically, when we did joint replacements, people would be in the hospital for 2 weeks, they wouldn't walk, everyone automatically went to rehab. It was a very painful operation. We've come a very long way in how we do the operations. And what you can tend to expect that if this is an uncomplicated total hip or total knee, usually the operations only take about an hour or hour and a half to do. You're usually only in the hospital for 1 to 3 days. And if you're independent, you have help at home and you can safely walk with a walker, not everyone needs to go to rehab. I often tell patients that if you're healthy, and you have your joint replaced, you're operating on a sick joint. You're not necessarily a sick patient. And so why do you need to go to a rehab with a bunch of other sick people and put yourself at risk for wound infections and other problems? If you can safely go home, now the key word here is safe. You have to clear therapy and you have to be comfortable, but that's something often scares people. They have a friend, they have someone went to rehab, something happened, or they want to be able to go home and recover in the comfort of their own home. And that's definitely an option for most patients if they have the right support. Now, if you do go home, we don't leave you on an island. You're going to have home health, therapy, people that come out to your house and work with you. So the idea that you absolutely have to go to rehab is just not true. We have resources that make it very feasible for even older patients to recover well in the safety of their own home. So in the old days, there were rules about you had to be in the hospital for X amount of days before you could leave, before you could go to rehab. I think there's been a change in the way we approach this in that we're less focused on the number of days that you're there and we're more goal-oriented. This is basically, have you walked a certain amount? Have you gone to the bathroom? Are you eating okay? Is there pain control? Once you meet these criteria, that's when we look to discharge people. It becomes less about, oh, the patient was here for X amount of days. So this is, I touched on this a little bit earlier, this is basically some of the improvements in joint replacement have brought us to this point where we're able to safely do these operations on more patients, expect longevity, and decrease many of the complications that were once more common. And these are specific to infection, the failure of the implants, dislocations. Now, some of these factors still exist, but I think as we learn and improve our techniques, we're able to minimize these risk factors for our patients. And so when you do a joint replacement now on someone, unless they're under 50 years old, even people in their 50s, if it's done correctly, for many of the implants, our goal is to do it correctly the first time so that that's the only surgery you ever need. You don't absolutely need to say that you're going to need another surgery in your lifetime. And I think our implants are catching up to that. So who in the audience either knows or has a hip replacement, knows someone that's had one done or currently has their hip replaced? Do we have some people here? Okay. So who here has heard of the anterior approach? Does anyone know what that means or related to a hip replacement? So when you talk about replacing the hip, the surgery is replacing the ball and socket of the hip. There's a metal cup that goes into the acetabulum. There's usually a plastic or ceramic liner that goes into that cup. There's a metallic stem, that goes into the canal. And the operation is the same no matter how you do it. So one of the approaches that has become more popular and falls into the category of what's called less invasive or minimally invasive is an approach called the anterior approach. And so it's not necessarily new. It's become more popular now, but it was actually described back in the 1940s. I just think that the implants and the techniques that were available then did not make it as routine, and over the course of the last 50 years, the common approaches, laterals and posteriors, which are more common among surgeons, are what most surgeons are trained to do. And so this is just an article from the New York Times where it basically highlighted one of the benefits of the anterior approach. It's not necessarily that it's a better operation or that it does better than a standard hip replacement, but I think it has the ability to allow some patients to recover a little quicker, at least initially. When you look at patients long term, I think everyone sort of gets the same result. So hip replacement is very successful. There's 500,000 of them that are done per year here in the US. The implants have gotten a lot better, and like I said before, we've gotten to the point where we're approaching a 30-year hip replacement that, if it's done correctly, it could last that long for you. Well, what are some of the problems that people have when they have their hip replaced? Sometimes they may feel that one leg is longer or shorter than the other after the operation. Sometimes in the immediate period, they're not sure what they're allowed to do. Some approaches place restrictions on patients where they can't sit a certain way, they can't cross their legs, they have to sleep with a pillow between their legs, they have to remember when they can bend, when they can't bend. And so these are some of the precautions that are placed on patients during the recovery of some of these approaches. And so one of the things that happens is when you replace the hip, it's deep down, it's coated in muscle. And the reason that people have precautions, and this is just an anatomic slide looking at someone's buttock, during a traditional posterior approach, you're cutting into part of the muscle. You're detaching some of these muscles from the back of the hip to allow you to do the operation. Once the operation is finished, you have to repair those muscles to the back of the hip, and it's that repair that creates the precautions. That's the reason that they don't want you to flex up and cross your legs, and why you have to sleep with a pillow, sometimes for a month after the operation. Once everything is healed, then many of those restrictions are lifted. This is just an example of a less common operation in this area called a lateral approach, but it's the same idea. It cuts into some of the muscle on the side of the hip to allow them to do the operation. And when they're done, they repair that muscle to the bone. So while that healing is taking place, there's a period of precaution. And so I had mentioned earlier the anterior approach, and so this is essentially the same type of operation. You're doing a hip replacement, but it's done in a way where you're not really detaching any of the muscles. So the end result is, because you're not cutting through the muscles, I think people are a little less sore after the operation, and more importantly, there's no major precautions placed on the patients. It's not impossible to dislocate the hip, but doing so With conventional motion, sitting in a chair, getting up, walking to the bathroom, the risk of dislocation is lower, and this is supported by the evidence in the literature. Now, not everyone does anterior hip surgery, requires some specialized training. There's different ways of doing it, but it's becoming more popular. I'm one of the surgeons in the area that does the surgery this way. There's a few others, and as it grows, I think you're going to see more surgeons doing it. So I think it's a better approach for the patient for the reasons that I mentioned. I think they recover a little quicker. I think that they have less postoperative pain in terms of the amount of medication that they require. There's no restrictions to range of motion. They have a shorter hospital stay because if they can mobilize a little bit quicker and they don't have precautions, I think they tend to leave the hospital faster. And so unless you're going to rehab, most of my hip replacements either go home sometimes the same day, but usually the next day. And the majority, I would say, more than 3/4 of them tend to go home, unless there's some safety issue where they live at home alone, they have no help, there's a lot of stairs, then sometimes they might need to go to rehab. It's better for the surgeon. I think that one of the things that we do when we do the operation, it allows us to get x-rays during the surgery and really ensure that the hip replacement is done appropriately in terms of sizing. And so as a surgeon doing a lot of these operations, I like the ability to do all of these intraoperative checks. So who's a candidate for this? Pretty much anyone could have a anterior hip replacement unless they have some traumatic injury that prevents you from safely using the leg. Another thing that I talk about is wound complications. And so the incision tends to be here on the front of the hip. And so if you have a large abdomen or your belly hangs over where the incision would be, I think that puts a patient at risk, not to do the operation, but it puts their wound at risk for healing. And so in my hands, that's one of the only times where I would do a more traditional lateral or posterior approach, where I would say I could safely do the operation, but you're at such high risk for having that wound become infected or fail, it's better to avoid that complication. So the hip replacement has an excellent clinical track record. I've demonstrated that a little bit talking about the longevity of the implants. I think technically the surgery is essentially the same operation, but the way that surgeons are trained and the way we approach pain, the hospitalization, I think we've gotten a lot better at it, and the implants have gotten better. And so the anterior hip, I'm not here trying to sell it as this special thing that's better than anything else. I just think it's an addition to what is already a very good operation. That's just so I threw in a few slides here at the end that are pertinent to things that I get asked about all the time in the office. Patients come in, they saw an advertisement, they had a friend that had something, they saw something in an article, and so there's a lot of terminology that sometimes people get caught up in technology. And just because something is new doesn't mean it's better. You know, there's a lot of ideas and things that come up. So people talk about minimally invasive. There's nothing minimally invasive about removing a joint and putting metal and plastic into the knee. But when you talk about minimally invasive, what that means is what kind of damage are you doing to the native structures? And so when you talk about knee replacement, this is just a picture of, that's the size of the skin incision, but you see that small window where the muscle itself is not detached. And so there are some operations that are able to be done this way. And so both hip and knee replacements can be done in this fashion, but the size of the incision itself doesn't truly represent what you're doing inside of the joint. And so if you're signing up for something minimally invasive, be sure that that's actually what they're doing for you and not showing you a small incision. People talk about computers. You know, computers are useful, but like everything else, they're a tool. I do not think that computer navigation is necessary for every joint replacement. I think we have a lot of tools that are available to us now to safely do the operations, but I think computer navigation is useful in the setting where the anatomy is abnormal, where you need that extra information of what the computer can tell you. But I don't think that the cost of what this equipment runs to the system has actually proven that it does a better job than the standard replacements that we have available. People talk about robots. There's a few hospitals in the area that have a robot, and so they want to know, am I going to have my replacement done by a robot? And I don't know about you, but you know, it's like why don't we have our airplanes fly themselves? You know, we have autopilot, we have stuff, but you need a human being behind the interface. There's something about the art of surgery and the ability to recognize when maybe the computer or the robot is either wrong or not wrong. So I think there's utility to these robots in terms of improving maybe some of our accuracy in measurements, but I don't think that the robots will completely replace the need for a surgeon that understands what they're seeing and doing during the operation. So just be careful to people that tell you that the robot's doing your surgery. Just make sure the surgeon's there too. Patient-specific, these are other types of implants that are done where people get special MRIs and CAT scans of their knees. They make special cutting jigs that allow you to do the surgery without drilling into the bone and doing additional things. I think these have some utility when there's deformity, similar to the robots, but there's a cost associated with this that I don't think that the evidence in the literature supports their use routinely. And so when you hear certain surgeons and doctors out there talk about that it absolutely has to be done this way, there's very few cases that specifically need this. And so, like everything else that I told you, it's about setting expectations and education. You should really understand what they're doing for you, because these patient-specific blocks are kind of like cookie cutters. You place them onto the knee and it kind of tells you where to cut. But there's still a component of the surgery that needs to be felt by hand to understand that the surgery was done correctly, not just putting a saw and cutting ends of the bone. Partial knee replacements. This is another thing that's a hot topic. If you have a partial problem, then a partial knee replacement makes sense. There's a little bit of a quicker recovery, you're taking less bone, you're not making as big an incision. But if you have arthritis involving other parts of your knee, a partial knee replacement will be an incomplete solution that may result in continuing pain and sometimes the need for additional surgery. And so just be careful if you're being offered a partial knee replacement unless they clearly explain to you that what the risks are of developing arthritis in other parts of the knee, or that you clearly only have pain in that area. Sometimes people will do these surgeries because they're a little bit quicker and shorter, but part of that is establishing a relationship with the doctor that's caring for you so that they clearly explain to you what's going on. Because I often see patients that have partial knee replacements and then in a short period of time require a total knee replacement, and then they'll say, well, I didn't know that this could happen. I thought that I was done. I did my surgery. Why did I still have pain? Like, should I have done the total the first time? And that's a challenging dilemma. And so one of the things that you should know as a patient is that you should be educated, and that's the goal. Ask questions and understand why you're being offered certain things. Don't just routinely sign up for an operation thinking that it's going to solve all your problems. I think that creates issues for patients. So I know that was a little busy at the end, but those were just some little topics that come up very often in my office. So to round out the talk, I wanted to add that. So thank you very much. I'd like to open up the floor. If anyone has any particular questions, thank you. I'll happily answer them to you. And they could be about anything related to joint replacement or orthopedics. So.